she was like, every single doctor in the hospital, like, came to the emergency room. There they call it A&E, like, because it, like, no one had ever seen it before. And I was like, oh, well, sometimes we don't even admit them to the hospital. Like, they just get discharged if it's just a flesh wound.
Dr. Elaine Reno, how are you doing, my friend?
Good.
Good. From Denver, Colorado, as you just posted. Yeah, where's everyone? Oh, Agatha also in Denver. Priyanka in Toronto. Zachary in Houston, Texas. Don't call it Houston. It's Houston, like the New Yorkers call it. What's going on? What's new and exciting in the emergency medicine world?
Well, someone's from Hawaii, which is where I would prefer to be from. I feel like there's been nothing new and exciting in the emergency medicine world except COVID-19 for 2 years now. So,
well, that's not new.
Nor is it exciting, Ryan. Nor is it exciting.
Is it slowing down? Is it slowing down? No?
Slowing down. So the recommendation or the reports are that we should start to finally level off this spring. So
fingers crossed. My wife and I have been out to dinner twice now in the last like 3 or 4 weeks. Like out inside, and I'm like, what is this? This is weird. Scary.
We have still not made it out to dinner.
Do it. Just do it.
One of these days.
It was good. It was worth it, and we didn't die. as the good doctor in what is that movie called? What's the movie where they go to Vegas? He goes, "But did you die?" Like the Asian actor who is a doctor, literally a doctor.
I know who you're talking about. He's an internist, I think, but I don't know the name of the.
Yeah, and he's on The Masked Singer. Yeah, he's awesome. Anyway, we're here to talk about emergency medicine, not just chit chat. So let's cover some emergency medicine. Yes, Ken Jeong, The Hangover. That's the name of the movie. Thank you. Let's talk some basics emergency medicine for those who love these types of questions. Emergency medicine, 3 or 4 years post medical school. What's the consensus these days?
Yeah, so it really depends on what you're looking at. So med school and then residency. Residency is usually 3 or 4 years, depending on where you go. And then people will fellowship from emergency medicine, and the fellowships are pretty variable. So you can do critical care, you can do ultrasound, you can do toxicology, you can do global health, you can do wilderness medicine. There's like this evolving branch of space medicine, which actually one of my friends does now. He's like responsible for figuring out how we get to people to Mars alive, which he works for NASA primarily. I was like, so if you're never successful in your lifetime, it's like
it's okay.
Yeah. Like you could spend the next 30 years and be like, someone else takes over. And
it's basically like being a weatherman.
Yeah. Yeah.
Yeah, whatever. Yeah, you're right. You're wrong. Whatever. It's all good. Okay, so 3 or 4 years. Sports medicine also. I talked to an EM-trained sports medicine doc who's a team physician for the Washington Capitals, the hockey team, and the ballet out in Washington. So
one of my partners who, if you want his contact information to bring him on this, is like the team doc for the Avalanche and the Broncos and the Rockies or something like that.
Yes, please. My wife would like their contact information because she'll fix all of their concussions.
They probably need that.
Yes, they do. Okay, we'll chat. All right. So 3 or 4 years post medical school, and then fellowship training if you want to do that. Are most of the fellowships 1 year?
Well, it depends. I think critical care is 2. Mine was like 15 months because I went to Europe and did the diploma in tropical medicine and hygiene. So it's variable.
Yeah.
But
okay. And then bread and butter emergency medicine. Probably not gunshots and stab wounds like the TV shows make it seem to be. What does that look like?
Well, there's actually a fair, unfortunately, number of gunshot wounds in the United States. So when I was at the London School, there were 100 physicians. We had 60 different countries represented, like all over the world. And far and away, I had the most firearm experience. One of my friends was like a physician in London, and she was like, "Wait, how often do you see gunshot wounds?" And I was like, "Pretty often." And she was like, "Our hospital has only had one." And I was like, "What? Like one a week?" And she was like, "No, one ever." And she was like, "I was like,
Did they do a case report on it?
Yeah, she was like, every single doctor in the hospital like came to the emergency room. There they call it A&E, like because it like no one had ever seen it before. And I was like, oh, well, sometimes we don't even admit them to the hospital. Like they just get discharged if it's just a flesh wound.
It's merely a flesh wound. The Brits know about
If
that.
it doesn't hit anything critical, you can go home.
Oh, yeah. I don't know. That's sad. Sad state of affairs. Okay. So bread and butter, coughs, upper respiratory infection.
It's been a lot of COVID the past 2 years, unfortunately. Some days I feel like 75% of my patient population is COVID. Wow. I mean, I think I've probably seen 1,000 COVID patients at this point, like give or take a couple hundred. But you know, like kind of common stuff, abdominal pain, chest pain, you know, infections. ERs are the safety net in America. And so we see a lot of like, you know, the weather gets cold. We see a lot of homelessness, like patients that don't have a place to go. And so, you know, the ER is open. We see, you know, like a lot of substance use disorders. So if you decide to like use methamphetamine in the middle of downtown Denver, and, you know, someone calls the police and the police show up, most of the time they'll call the paramedics and send you our way, and we'll let you metabolize out whatever you've taken and then let you go home. So a lot of stuff like that ends up in the emergency room. Same with like, you know, I don't know, other drugs, alcohol, things like that. When marijuana was first legalized in Colorado, I felt like we got a lot of like DIA, which is our airport, like marijuana overdose is the wrong word, but people would be like going to go fly home and figure out they couldn't fly their edibles, and then they take too many of them because they paid for them.
I spent good money for this. I'm not going to waste it.
So, I mean, you know, it's like, it's a variety. It's also sort of cyclical. We call the summer trauma season, although Colorado has kind of a winter trauma season related to like skiing and snowboarding. And then obviously winter is respiratory season, although COVID has kind of thrown that for a loop. So
I thought it's just gonna go away. It's like, you'll see, it's just go away.
It's not going away.
No. Okay.
I wish.
All right.
Anything to get it to go away at this point.
All right. So we're gonna do a fun little case here for everyone to watch and listen to. I'm gonna share my screen and do this. Virtual shadowing. That's what I'll do. Let me do this first. Make it big. Yeah, there we go. And we shall go. How's that look? Look bueno? Yeah, it looks bueno to me. All right. So I'll click play, and should we just let it go through, or are you going to stop and we'll ask questions throughout? What do you want to do?
We can let it go through. At the end, there's a debrief. We can either watch the debrief or debrief virtually with the students with their actual questions.
Yeah, let's do that. All right.
Hi, I'm Dr. Smith. What's your name?
Hi, I'm Thomas.
Hi, Thomas. What's bringing you in today?
I woke up this morning with a fever and this cough that I can't quite get rid of.
Okay. I'm so sorry. Yeah. How long has it been going on for?
Just since this morning.
Just this morning. Okay. Yeah. What other symptoms are you having?
Feel a little nauseous as well.
Okay.
And my head is just killing me.
Okay.
Yeah.
And those symptoms, when did they start?
Also this morning, kind of when I woke up.
So last night you were feeling just fine.
I'm like feeling relatively okay. Yeah.
Okay. All right. And ever have symptoms like this in the past?
Not like this before, no.
Okay. Yeah. No. Tell me about your medical history. What medical problems do you have?
I was recently diagnosed with cancer.
Okay.
I'm on chemo. I had my first chemo was a week ago.
Okay. I understand. Yeah. So first chemo was just a week ago.
Yeah.
Okay. I see. And all these symptoms just started today.
Mm-hmm.
Okay. Have you had a chance to talk to your doctor about these symptoms?
I hadn't. I just came straight here. It was a little scary, you know, with chemo and everything. I thought I'd just come here.
Yep. You did the right thing.
Yeah.
We're happy to see you and make sure things are looking okay. I'm just going to run through a number of other symptoms that you may be having.
Sure.
You said you had a headache and some
Yeah.
nausea, and then the cough and a fever.
Yes.
Okay. Anything else like belly pain or diarrhea?
No.
Any chest pain?
No, not really.
Okay.
No.
Any neck stiffness at all?
No.
Sore
I feel
throat?
pretty okay. Just from the coughing, but nothing else.
Yeah. Any problems urinating or hurt or burning when you pee?
No, I think that's pretty okay today. Yeah.
Rashes that you've seen anywhere?
No.
Okay. All right. And so I know you have the cancer and you're just had chemo. What medications do you take? Is it just the chemo?
Just the chemo, yeah.
Okay. Yep. I understand. Any allergies to medications?
Not that I know of. No.
Okay.
Doc, I have already 2 IVs in them. I've
Okay.
drawn some labs, 2 sets of blood cultures,
Fantastic.
and got a liter of lactated ringers running on them. I see a SAT is kind of low in the 74s. Just going to put some high flow oxygen on it.
Fantastic. Thank you. That sounds great. That sounds great. Thank you, Glenn. Well, I'm worried about you. I'm worried that you have an infection. A lot of people, and you may have been explained this before, but a lot of people after chemo, they have a lowered immune system, and that can make them susceptible to getting bacterial infections.
Okay.
I want to make sure that, you know, you're based on everything that we're seeing here, that, you know, you don't have an infection, but I'm worried that you might. Is it okay if I do an exam?
Yeah, go ahead.
Okay. Just breathe normal for me. Your heart rate sounds a little fast. Go ahead and lean forward and listen to your lungs. Take a deep breath. There you go. Good, thank you. There are a few crackles at the bases of your left side there. That might represent a pneumonia. We'll get a chest x-ray. Any pain in your belly when I press?
Not really.
Okay. All right. Just gonna look at your skin, looking for any rashes. Around to this side. Okay. All right. Alrighty.
Okay, Dr. Smith, his lactate is 4.3. And his,
Okay.
White count is 14.
Okay. All right. Yeah, those numbers make me think that you might have an infection. Your temperature's up, your heart rate's up, and your oxygen saturation's a little low. I'm glad that it came up to normal level once we put you on oxygen. Next steps, we're going to get a chest x-ray, collect some urine from you, and wait for some more labs to come back.
Cool.
Do you have any questions at this time?
Not right now.
Okay. We'll get you feeling better. I'm glad you came in.
All right, what do we think? Want to bring on some students and ask some questions?
Absolutely.
All right. If you want to come on, raise your hand. I'm going to clear out the 2 that are in there. If you want to come on, raise your hand. We'll bring you on. Can ask some questions. You can be asked questions. Have no fear.
Be brave.
Be brave.
Go boldly into the night or onto the webcam.
Go where no man has gone before. Let's continue our space theme. Although we gotta change the gendered, where no person has gone before. Hello, Emily. How are you?
Good.
Elaine, you got a hard question for Emily?
Why don't we let Emily ask the hard questions?
Okay.
So is it like about what to do or what you think it is or what?
What do you think is going on?
Well, I mean, it sounds like what he said. It sounded like it's an opportunistic type of infection. The crackles in the lung sound like there's something in there, like pneumonia-ish. But like the heart rate and the low blood pressure, the fast heart rate and the low pressure are concerning. It sounds like shock starting.
Perfect. So can any of you guys define what shock is? What do you think?
Isn't it when like the kids don't get oxygen?
That's a great, that's part of it. So people define shock in like different terms, but shock is essentially like the pre-death condition. So your body is not getting enough blood flow to your essential organs, and as a result, you're not appropriately perfusing your heart and lungs, and so you're seeing hypoperfusion, and you're seeing the development of end organ damage. So shock is, in most instances, reversible, but needs acutely reversed if you want someone to live. What else stuck out from you guys about this case?
Any of you? Daniel, Sawa?
Because I was a little surprised how quickly, he was fine yesterday, and then he had symptoms the next day, and it progressed so quickly, and he only had chemo not too long ago. So I guess I was kind of surprised how quickly it progressed.
Yeah, so it's not actually that the chemo itself would have led to shock. The thing is that the infection, so chemo, depending on your type, reduces your immune system efficacy. Your immune system doesn't work as well, and that allows opportunistic infections to set in, or just sort of normal day-to-day infections that people get that then rage wildly out of control. And it can set in very, very quickly. When we're talking about shock in the setting of an infection, we talk about something called sepsis. So the term we use is septic shock. And these patients can crump or crash pretty aggressively. And so with septic shock, we talk about something called early goal-directed therapy. Have any of you guys ever heard about early goal-directed therapy? Okay, Ryan, do you remember early goal-directed therapy?
I know how to podcast. My goal is to keep people alive, so I'm just gonna throw everything at you to keep you alive, and then we'll figure it out as we go and reduce stuff and change things.
Do you guys want me to pimp Ryan? Because normally he's the one that asks all the hard questions.
No,
we'll see
no,
what
it's not nice.
So someone named Brenda said piperacillin and normal saline. So 100% right. So what we say with early goal-directed therapy is early antibiotics, early fluids. And so we get IV antibiotics on board as quickly as possible. And then we give you a 30 cc per kilogram bolus based on ideal body weight. So essentially it ends up being 2 to 3 liters of IV fluid to try and get your intravascular volume back up. And then if your blood pressure is still low, then we can put medicines into your IV that cause your blood vessels to squeeze down. They're called vasoconstrictors. There's some that squeeze blood vessels. There's some that are sort of like a kick to the heart. And so we can use different combinations of those to squeeze the blood vessels down and get the heart going, to get the heart more effectively pumping or pumping faster, so that we get greater blood flow throughout the body. Because what happens when we have infections like this is you get what's called vasodilation. So the blood vessels dilate, and then you can get what's called capillary leaks. So the veins, capillary leaks. So the capillaries will get leaky, and fluid will sort of ooze out. And so then you don't have enough circulating blood volume. And so then your organs aren't getting enough blood flow. And complications develop, including, if you're not getting enough oxygen, you can start having some anaerobic metabolism instead of aerobic metabolism in your organs. And we can trend something called a lactate to kind of see what that's looking like. So very complicated, but sepsis is a common condition we see in the ER, and the goal is always early recognition and jump on it fast.
So is the quicker heart rate, is that to compensate for the lower blood pressure and the lower blood volume?
Yeah, 100% right. So your body's really smart. It's smarter than any physician you're going to encounter. And so when your blood volume starts to drop like that, the heart kicks up there's different types of shock, but in most shock, the heart starts picking up and beating faster and faster and faster to try and compensate. Because when we think about how much blood is circulating, a lot of that depends on how fast the heart is beating. And it's the same concept, right? When you go for a run, one of the reasons your heart starts beating faster is because you're using more oxygen in your muscles. And so you're using more oxygen and you're generating more waste products. And so you start breathing faster and your heart starts beating faster because your body is trying to push more oxygenated blood out into your tissues and pull back more deoxygenated blood and waste products as quickly as possible. So it's essentially a very similar concept to what happens when you go for a run. Just, runs are healthy and sepsis is not. So
that's the tweetable. Runs are healthy, sepsis is not. Unless it's the
you can
runs.
put that on your next t-shirt, Ryan.
The runs are not healthy, but running.
Yeah.
Can I ask
That would
if,
be like the perfect ER coffee mug.
Yes.
I'm curious if he hadn't come in, how long would he have, and how quickly would he deteriorate after?
That's a great question. So much of that depends on personal factors, like who you are, what are your like physiologic reserves, how healthy are you at baseline. Younger is always better. Kids tend to like sort of like hold their own crash. Same with like, younger people. Older people can sort of decline earlier on in the clinical course. So it's really person dependent. And it's also kind of dependent on what your infection is and how bad it is. There's like some infections that are just, ugly, and people can get sicker faster. And it sort of depends on like, what else is going on in your body, just what are your physiologic reserves like. So
I have a question. I've seen a septic patient. He was like really lethargic and it was yellow. So my question is, when do you determine that the patient is septic versus is just being a local infection?
That's a good question. So when we think about sepsis in the setting of infection, there's specific diagnostic criteria we use. So we look at like heart rate, we look at white blood cell count, we look at respiratory rate. So we use specific diagnostic criteria. When we go from sepsis, which is a diagnostic criteria, so essentially we have these factors we use. And so we say, you meet these factors and you have an acute bacterial infection. So we would say you have acute bacterial sepsis. And then we can go from sepsis to septic shock. And shock is when we start to see hypotension. And one of the common things we'll see with that is altered mental status. So patients, if you're not perfusing your brain, you're confused. And so the brain needs glucose, oxygen, and blood. And if it's not getting one of those three things, then your patient starts to get real confused on you. So sometimes what we just see initially is altered mental status.
Gotcha. Thank you.
Yeah.
Sawith, you're on. You haven't talked. Say something. Ask something.
Actually, my question was, how often do you see cancer patients like who are in sepsis?
Yeah, so that's going to be site dependent where you work. My hospital is the largest academic hospital in the state of Colorado, and it runs like a very large number of clinical trials for cancer patients and things like that. It also tends to be a big cancer center and a big referral center for malignancies. So as a result, I feel like we see a lot of cancer related complications. It's like situationally dependent based on where you work, right? If you, like, I grew up in a town called Waynesville, Ohio. It's pretty rural. My dad has a 10-acre farm. Like, there's a local ER there, assuming they haven't closed. And my guess is the volume of cancer patients they see is probably pretty small. They probably see, frankly, more tractor accidents than, cancer-related septic shock. So it's a little bit dependent on where you live. Whoever the person is from Hawaii, like, they worked in some, small island emergency room, they probably see more surfing accidents than septic shock. It's just dependent.
Well, what are the chances that the doctor and the tech that were treating the patient would get the same infection, or is he the only one who's susceptible because of it?
Yeah, that's a really interesting question. So most of the time, so pre-COVID, unless we thought the patient had tuberculosis or bacterial meningitis, we never wore masks in any patient's room ever. The caveat being every single year I caught about 5 colds, and I caught them all from work always. So normally in this instance, no. Like, when you have a cancer patient, their immune system is depressed, and they often get infections that you've been exposed to all your life. It's just never sort of developed into an infection before. So like your body is covered in bacteria. Like you have bacteria all over your skin, and it doesn't lead to infections on most of you, right? If you became diabetic or underwent chemo, then every little cut in your skin could lead to an infection. But for the most part, like the risk is very small. There are some specific ones. So bacterial meningitis is actually a vaccine preventable disease. And as far as I know, everyone who works in an ER is probably vaccinated for it. But that's one that potentially could be contagious. We used to wear N95s for tuberculosis concerns. Since COVID has hit, I feel like that equation changed a lot because COVID itself is viral. So we wouldn't say that a patient developed bacterial sepsis from COVID because it's a viral illness. And antibiotics don't really treat it. We are very aggressive about masking in the emergency room. So we wear a mask and we wear eye protection. And then if we're doing anything that's considered an aerosolizing procedure, so like if you have the patient on more than 6 liters of oxygen, if you have them on something called CPAP or BiPAP, if you're intubating them, all of those are considered aerosolizing procedures. And so at that point, we upgrade to either half-face respirators. I have mine somewhere around the house. I don't know where it's at. Or an N95. And for the first, 6 months or the first year, they really aggressively followed healthcare workers in some of my hospitals, including at one of the hospitals, they were they took volunteers and they were blood testing them every week to see if they seroconverted for COVID. So if they showed antibody positivity, because nobody knew if masks were going to work or not. And it does not seem like healthcare workers catch COVID at work if they're wearing. So of those 1,000 plus COVID patients, I've been all up in their business. I've intubated them. I've suctioned them. It's not like I'm treating them from the back of the room. And knock on wood, I have never yet caught COVID from a patient interaction. So, but I never see a patient without a mask and eye protection on ever. I don't even go in the room.
Do you think that'll be here to stay?
I hope we never stop masking in healthcare settings. Because, we've always masked in the operating room and we know that patients are safer as a result of it. It seems to me like, if you're a heart transplant patient or you're a cancer patient and you go to the hospital, it just seems like everyone's safer if we just keep masking in a medical setting. So plus I like not getting colds. So I don't know. We'll see. The idea that we'd go into an operating room without a mask or gloves, even 15 years ago, is absurd. You'd get thrown out of the OR. I wonder if that's just what medicine is going to be like too. And that's fine. 50 years ago, they didn't operate with masks or gloves, but all the women died during C-sections from infection afterwards. So
that was just the ether.
Yeah. Yeah. They didn't wash their hands at some point, right? Florence Nightingale. That's what she was all about.
Yeah.
So
I was wondering, with shock, it's sometimes said that the person feels an impending sense of doom. What causes that feeling? And I
don't know if anyone knows that what causes that feeling. We hear that often in patients who are doing very poorly. We'll hear that with patients having heart attacks. We'll hear that with sepsis. I can tell you, I personally had a kid and they put what's called a spinal. So they put a catheter in my up against my spine to numb me, and I had this horrible reaction, and I ended up with 2 rounds of pressors and on a ventilator, and I had a terrible impending sense of doom till they knocked me out and cut the baby out of me. So I don't know what causes it. I don't know if anyone does. So for the person who says it sounds like a panic attack, I don't think it's a panic attack. I see lots of patients with panic attacks, and they will often have an impending sense of doom. But acute heart attacks feels different somehow. So, but maybe one of you guys will figure that out, why our brains can sense that something's wrong.
I'm curious, how have you been able to stave off burnout?
The vid? I was initially pregnant when it started, and
no.
For the first
not COVID, burnout, he said. How have you been able to stave off burnout?
Right. I was we can talk about this, but I just wear my mask. How do I stave off burnout? I feel like the ER community is pretty burnout right now. As an overall thing, I think for me, I have gotten a lot more careful in the past 2 years about the projects I commit to. I only commit to things that I find personally valuable. So things like mentoring pre-medical students, mentoring medical students, like teaching, things like that. So things that I personally find value in. That's the first thing. I exercise every day and spend time with my family. I try and go outside every day in the sunshine because I live in Colorado. Those kinds of things. I think being protective with my time is one thing that's been very helpful. And just like learning how to say no to things that, right, if I do something, it's either like, it either has to be something that is required by my job or like brings me a sense of joy. Like I don't do things out of obligation anymore. And I think that helps a lot too. So at some point, I feel like early in your career, you do a lot of things out of obligation or because someone asked you to. And that's probably the right thing because you're trying to figure out what you actually like and what you actually enjoy. But at some point, you just learn how to say no, and that is very helpful too.
All right, I'm going to rotate out some people, and new people can come on and ask some questions. We'll get going. Are we able to talk briefly, tease the research stuff going on, just to get people interested and stay tuned for it?
What do you mean?
Like the type of survey stuff that you want to do?
Sure.
So talk about it.
What specifically do you want me to talk about?
So in theory, we are trying to reach some pre-meds to do a survey to find what are we hoping to find out? Yeah,
so and you guys are welcome. So Ryan and I are working with a physician who's a radiologist at UCLA and then a sociologist because he knows the most about emotions, I guess, or human behavior patterns. Honestly, I wasn't sure what sociology was till you told me.
All I know is emotional damage from TikTok. You probably don't do TikTok.
I don't have a TikTok account. I only watch Dr. Glaucoma and Flecken. And I only watch Dr. Glaucoma and Flecken on YouTube. So
yes, we love him. Okay. All right, keep going.
So what we are trying to look at is, right, so this is kind of my opinion and Ryan can weigh in too. I feel like as a medical community, you guys spend the first 4 years in undergrad and you're taking these very difficult classes and there's very little shadowing opportunity and there's almost no mentorship. And it becomes very cutthroat and very competitive. And then you step into medical school the first day and all of a sudden we're like, oh, we want you to be team players. We want you to have emotional intelligence. Now that you've been accepted, you're entered into the hallowed halls of medicine and we want you to be emotionally well. Except we sort of spent the past 4 years selecting for the very opposite traits that we now want you to have in mass. And I feel with COVID and people going virtual, to me, the sense is it's even worse, right? People are taking classes online. You're not getting to socialize. People have been off campus. All of the good parts of college have been ruined. And the worst parts, sitting in a virtual Zoom lecture, have been left behind. So maybe you guys feel differently, but that's what it seems like to me. I can't imagine doing college during COVID. It sounds horrible. And so what we wanted to do is look at a couple points, including they've done this research in medical students, residents, and practicing physicians. What are the underlying rates of burnout? What are the underlying rates of anxiety and depression? How are pre-medical students coping? What are their support systems things like that? Because I think if we want healthy, happy, and emotionally well physicians, we can't wait till you're a doctor and be it's time for you to be emotionally well. We need to start teaching the importance of emotional wellness, the importance of mental health, the importance of self-care, when you're taking OChem, and it needs to be, if we want empathetic and healthy doctors, it needs to be as important as OChem to take care of yourself. So that's kind of what our survey is looking at and where we are at. So hopefully when Ryan sends it out, you guys all do it so that we can gather more data.
Yeah. If only, right? My whole platform is collaboration, not competition, trying to instill these kind of thoughts into people that the person sitting next to you in OChem or wherever is your future colleague. And so don't let them borrow the book and steal 10 pages from it, hoping that they'll fail the exam. It's not cool, dude. It's not cool. So it's
Wait, can I say something in here?
Yeah.
Someone said that the increasing suicide rate in medical students and residents, that there's actually data that every single year we lose an entire medical school graduation class of physicians to suicide. So physicians have one of the highest suicide rates of any profession, and they also, this is not shocking to anyone, tend to be particularly successful at suicide. So most attempts are successful, which most suicide, when people attempt, it's not successful. So there's an opportunity for intervention there, because honestly, most people don't know how to kill themselves. And so there's an opportunity for medical intervention and psychiatry intervention there. But with physicians, it's most often the opposite. Like they don't tell anyone that they need help. They refuse to admit it. They struggle. And then when they go to attempt suicide, they're successful. And so it's one of the highest, I think dentistry is another one that's really high, but in general, physicians have a very high rate of suicide. So
yeah. So if you're struggling, reach out for help, please.
Someone said, can non-traditional students do the survey? Yeah, the goal is to look at everyone who wants to approach medicine, because non-traditional students become doctors just like traditional students become doctors. So
yeah, that is true. Cool. Yeah, I'm excited to get that out and look at some of the data and see if we can make some differences. Hello, Lisa.
Hi, can you hear me?
Yep.
So I was going to say, I think I've made the mistake of like going on Reddit subreddits too much. And in an attempt to like find out more about what med school and residency is like, I've just heard a lot of horror stories that make me worry if I'm going to be able to like handle the stress period, especially of residency. So, and I haven't been able to shadow or really actually speak with any physicians and say like, hey, what was this really that bad for you?
Yeah.
Or yeah.
Well, can I say something real quick? Just and then I'll let you talk. You always have to take those things, I think, with a grain of salt, because the negative voices are the loudest ones who want to go tell the world, my program sucks, my school sucks, life is terrible. Right? It's like going on to Yelp. It's like the people who want to complain will complain, and then all of the people who are happy with their meal are like, whatever, I'm just gonna go home and relax. So you gotta, it's a very big selection bias when looking at the people who are posting. All right.
And the other thing I'd say, like, remember that anyone can write. Media literacy is a huge problem right now. Like it is a worldwide problem that has facilitated the spread and the poor outcomes of the COVID pandemic, right? Because a lot of people lack media literacy and don't understand that like any random person can make a meme and spread it on Facebook, and that doesn't mean it's true. I am trying to like explain this to both my father and my grandmother. They're like, well, why would they post it if it wasn't true? Gosh, stop, please. Please just stop. Please. Like media literacy should probably be taught in the schools. And I think probably anyone under the age of 50, is hopefully somewhat media savvy, and anyone above, I don't know, where do you think the cutoff is? Like 45, 50, their media savviness. They need some education on how you can just build a meme in PowerPoint and post it on Facebook, and it doesn't make it true. So first, everything right you take online, you need to check your sources and read it with a grain of salt. I would say that in general, for me, medical school was more difficult than residency. You know, I struggled with like sitting in classrooms, like reading textbooks, going to lectures, because it felt like, you know, it's just another 2 years of the same crap you just spent 4 years doing. Medical school is changing a lot, in that we are really trying to get students to the bedside much faster. And the learning is evolving from like memorizing book stuff to like learning from a case standpoint, which is how doctors learn, right? Like I do continuing medical education all the time, and we learn by cases. And so there is a huge push to create a better adult learning curriculums in medical schools. Residency is hard, don't get me wrong. But for me, have you read the Harry Potter books?
No,
Anyone?
actually.
So like the best analogy I have is like, you know, he's a wizard. He goes to Hogwarts and like everything is like so new and exciting, and he's like doing all these incredible things, and it's hard, but like at the same time, it's like incredible. So here's what I would say. Like, residency was really difficult, but I spent, like 8 years becoming a doctor at that point. And then like all of a sudden I'm actually a doctor. And I'm like, I like remember the first time I was in the neurosurgery case, and like I was like looking at the brain, and I was like, oh dear Lord, the brain is beating. Like, the brains are actually pulsatile if they're healthy. And so it was so pulse. And I was just like you could, if someone had turned to me and been like, hey, you can go home right now, I'd have been like, nope, you're going to have to hog tie me and drag me out of here if you want me to leave, because this is the most interesting thing I've ever seen. And so I think while residency is difficult, at the same time, you are finally doing the thing that you have wanted to do for 8+ years at this point. And not only are you doing it, it is fascinating most of the time. And so I think that I sort of think residency is hard, but I sometimes think the difficulty of it is a little bit oversold. I'm not going to say it's easy, but I'm not going to say that I wouldn't do it again if it was the only way to reach my career. Is that fair?
Yeah, I think that's what I want the answer to is, would you do it again?
Yeah, I would do it again. I wish residency was 40 hours a week instead of more than that, but simultaneously. And then the other thing is your residency class becomes your social circle. And so you're doing a lot of your socialization at work, seeing your friends, things like that. They become very close to you. Same within medical school. And so I think, it takes some of the burden off of that. I don't know. You should ask someone who did a neurosurgery residency, because they might feel very differently. But I think it was worth it for the career.
Thank you.
Thanks, Lisa. So the question would be, Elaine, if residency were 40 hours, do you think you would see enough cases to be as confident and self-sufficient as you are now as an attending?
No, you need the volume. That's the problem. And honestly, even when I came out of residency, I went to a very, what is considered an EM, a very difficult, very aggressive residency program where we worked a lot. And I remember my very first day as an attending, there was a helicopter crash. And they were evacuating these patients out of the mountains, and the helicopter crashed. And in those moments, when shit is just hitting the fan, you never regret that extra training. Sometimes you just want to throw up because you're oh dear Lord, everything's going to hell in a handbasket. And at no point during a crisis do I ever think to myself oh man, I wish I'd done a 3-year residency or gone to an easier residency. Every time something the world explodes in the emergency room on me, I'm always oh, thank God I went to Denver Health. Thank God I did this residency. Because at the end of the day, the responsibility is on you. And I don't think, even though residency was hard, I would never want to step into my role and not have had the training I had. And even sometimes now I'm I wish I could have done a rotation in this while I was in residency. If they'd given me an optional 5th year to do electives, I would have taken it.
Yeah. I was on Reddit the other day, and there was a student who posted warning, if you're applying to Dartmouth Medical School, this is what they just sent out to 3rd years. And it was just a very benign, okay, 3rd years, welcome to clinical rotations. You may be expected to work on the weekend. And the kid was this is not acceptable. I want to go. I want you to teach me. And then I want to go home. I want to go home and spend my time how I want to. I'm medicine is probably not right for you, my friend.
Yeah. If that is how you feel, then just don't pick medicine. I don't know, be a computer programmer. Lots of great jobs out there.
Yes.
You can live anywhere in the world.
Yes.
And work from home.
Chelsea, hello.
Hi, thanks for being on here. I just, you definitely piqued my interest with this research study that you're talking about doing. Are you trying to glean, are pre-med students on average, emotionally unwell? I've heard of like that med schools have programs to facilitate like mental wellness and offering therapy and those kinds of things. But like, are you specifically looking at like, how is undergrad preparing you to be emotionally stable or viable or whatever? Or like,
I don't think we're even that far, right? No one has actually like cared is the wrong word, but truly it feels like no one has ever even cared enough to look at like pre-med students and ask how they're doing. Like once you're in medical school, like, you know, we study medical students' emotional wellness, like we study physicians' emotional wellness, but it feels like no one has even bothered to look at the pre-meds. And I actually think from like a emotional wellness standpoint, for me, undergrad was the hardest because you don't know if you're going to get in. And so you're doing all of this work for like a maybe career. And then if you don't get in, then you have this science degree that maybe is valuable or maybe is not, right? Like there's not a lot of Bachelor of Science jobs available. And so I think for me, the time in my life when I was the least emotionally well was probably undergrad.
but
And
then
so
like, is it also about emotional competence? Like not only like, how am I doing individually, but like, how am I relating to others? Like, is that something you think that medical schools could incorporate into being a part of like the admitting class?
medical schools are starting to do that. And I think that we could eventually look at it. But right now, like I think we're just trying to look at how our pre-meds, like what is their current emotional wellness, right? If we know that in 10 years, they're going to step into careers of be doctors and they're going to have the highest professional suicide rate, like where does that start? Does that start when in residency? Does that burnout start when you're a practicing physician and it's not living up to your like expectations? Does it start in med school or does it start sooner? And so I think we're just trying to start by looking at like, what is the emotional wellness of our subpopulation? What is emotional wellness of pre-meds? And then how we expand it from there, like you could make an entire research career on this. And on probably finding people who will be overall better doctors than whatever admissions criteria used now. I honestly think probably the current admission criteria, and Ryan, feel free to jump in, that schools use, and it's slowly changing, but it's probably not producing like the most emotionally intelligent physicians that we could have, right? Like so much of it.
No, the MCAT is the best predictor at bedside manner. Come on.
Like it feels like so much of it is GPA and MCAT, and that has changed a lot in the past 10 years, but no one has ever proven that the MCAT makes you a good physician.
But no one has disproven it. So I will keep doing it. I am the AAMC. Right? Hello.
It's just like we've decided that like being smart was the thing that was the most important, and like fine, but like is it actually the most important? Like there's lots of data that actually shows that if patients like identify with their physicians and feel their physicians care about them, then there are better outcomes, which would mean that you could argue that, like, I don't know, empathy is the most important characteristic. It's just that the MCAT is easy to measure and empathy is not. So
yeah. Well, the SJT from the AAMC, which they're charging $100 for, will try to measure empathy, just as Altus has used Casper to try to measure that kind of stuff. So
I find the likelihood that a computer quiz to measure empathy is going to be effective is somewhat small.
Yeah. Oh, well, even the SJT, right? The SJT is multiple choice. At least Casper is you just write as much as you can and work through kind of your thought process, or at least the thought process you think they want, which is what a lot of people do. So yeah, I'm all for trying as long as we can get rid of this stupid MCAT. And but my hope, silver lining with the pandemic, is that there were a couple schools that accepted students without an MCAT score last year. And so I'm hoping that in 4 years' time, or maybe in 2 years' time, post preclinical years, we'll have some data. It may not be a very strong, powerful data set, but we'll have some data that shows, oh, look, those kids did just as well as the other kids getting through the preclinical years. Amazing. Who knew? So,
well, I think what you're doing is a really cool project, and I'm looking forward to hearing about the results of it. I'm a little bit bummed, if I'm honest, that you couldn't like preclude me from having to take the MCAT, but you know.
One day, yeah. I will try. Yeah, I was just having a conversation with a parent in a pre-med parent group about step 1, and she's like, "Well, there's got to be utility for it. They've used it for so long." I'm like, to screen applicant, it's a licensing exam. It doesn't have to be pass fail. Like, we set a bar. Like, you need to know this to practice medicine. And she kept arguing. I'm like, well, let me ask you this. Like, when you go find a new doctor, do you ask them what they scored on step 1 so that you know if they're a better doctor than someone who just quote unquote passed? Like, probably not.
You know, step 1 is switching to pass fail, right?
No, I know. That was the whole conversation, was it's switching to pass fail, and she's concerned about, oh my gosh, like how are we going to know if doctors are going to be good enough? I'm like, pass is good enough. That's the bar that we have set.
Also, I'm gonna go like totally crazy here and argue that potentially standardized testing is not the best way to identify, right? Like, some people are just bad at standardized testing.
Yeah.
When you're actually in your medical training, like all day long, you're like working with physicians above you who are educators and who are trained to evaluate and assess like learners and their knowledge deficits and gaps. And so honestly, if you threw out all the standardized testing, you'd still, I think, graduate very competent physicians, because all of the like all day long teaching, learning, assessing that occurs in a medical school with student preceptors is frankly probably a better marker than a standardized test.
Probably.
I mean, I have a brand new med student I'm working with, and she's lovely, but like, I can already tell you, like, I don't need to see her step 1 or step 2 scores to tell you what she's good at and what she's not. Like, because, you know, I talk to her.
Human interaction? No.
What a concept.
All right. Well, Dr. Elaine Reno, it was a different session tonight. We got a good case in, got some good discussion in. It was a fun night. That's what happens when you have friends on eShadowing. We just chit chat. But hopefully it was helpful for other people. Emergency medicine is the game. It's fun. It's out there. We need EM docs. Although, let's pause for 2 seconds. I want to hear your take on this. I've heard rumblings from graduating emergency medicine residents that finding emergency medicine jobs is getting hard. What's going on out there?
So during COVID, pretty much every hospital system initially stopped hiring, and a lot of that like has to do with the finances of how medicine works. But a lot of hospital systems, I don't know why there's this like never-ending persuasiveness that hospitals get paid more for COVID patients. But a lot of hospital systems,
technically they do, right? If you look at it at a group code, because they need more care.
Yeah, I mean, they might just like get more interventions, right? Like, a lot of billing is bundling based on like, you know, if you have like a septic patient and then you have a COVID patient and the COVID patient ends up on dialysis, then of course it's going to like cost more because, you know what I mean? I think they get more interventions, which is probably why it costs more. They also spend more time in ICUs than like anything else. It like to have a pneumonia patient in the ICU for 6 weeks is unheard. I've never even seen that. But to have a COVID patient in the ICU for 6 weeks happens all the time. So total tangential. I think a lot of places put their hiring on freeze because they were concerned about like the financial status of the hospital or whatnot. There's a concern that there's going to be too many ER docs. I don't know, Ryan, you know, like when we were in med school, I feel like everyone was like, don't become an anesthesiologist because there's never going to be any jobs and the CRNAs are taking all the jobs. And then I remember like the same thing was said about OB, and it was like the midwives are taking all the jobs. There's never going to be any jobs. And then I feel like radiology, I was told not to be a radiologist, which I'm not. I could never be a radiologist. It's just not my skill set. But people were like, oh, computer intelligence is just going to like take over for that.
Yep.
I don't know.
It's like Branch in the Trolls. The Bergens are coming. The Bergens are coming. Like, but he was right eventually.
Yeah, throughout the past 15 years since I've been in medicine, I've heard at least 5 different specialties that are going to be ruined for some various reason.
Yep.
Knock on wood, none of them have. So
Yep.
I think people are adaptable, and there's just fundamentally not enough doctors in the United States. So the likelihood that we have this huge glut of physicians in some specialty, I don't know.
Yeah. All right.
We'll see it.
That's the hot take. All right, everyone. Dr. Elaine Reno, thank you so much for coming and hanging out. I look forward to chatting. Everyone, have a wonderful night. We'll see you next time. Bye.
Guys, I'll put my email address in the comments. If you have any comments or you want to email me or you hate me and Ryan's research idea, feel free to reach out.
Yeah. Put it in there. Everyone have a great night.